Well, thank you, Chuck, for your very generous introduction for me. It's my great honor to be invited here today and give this talk to the members and distinguished guests of IHPBA. My topic here for today is from discovery to international consensus on the management of IPMN of the pancreas. I have nothing to disclose. Although some of you may not know, the first case reports of IPMN in the world were published from Japan in 1980 and 1982 with the name of mucin-producing tumor of the pancreas. This entity called our attention due to a patulous open orifice of the duodenal papilla caused by passing of profuse mucin. Many years later, our attention, the name of the disease was changed to IPMN according to the WHO classification and divided into 3 macroscopic types shown in this slide. This classification is important as the frequency of malignancy is different between the branch duct type and other types. The main duct type and the mixed type are basically surgical indication due to the high prevalence of malignancy in these subgroups. However, the management of branch duct IPMN is still debatable as it has a more indolent biologic behavior. At least 8 guidelines or white paper have been published to date regarding the management of IPMN or other cystic diseases of the pancreas. As sufficient high-grade evidences are not available yet, all these guidelines are consensus opinions of experts in this field. The international consensus guidelines issued by the International Association of Pancreatology in 2006 were called Sendai Guidelines and revised in 2012 as Fukuoka Guidelines. The Fukuoka Guidelines proposed 2 categories of predictive signs to stratify the possibility of malignancy. 3 high-risk stigmata to suggest immediate resection, and 7 worrisome features to recommend further evaluation by endosonography. If no worrisome features are present, no further initial workup is recommended, although surveillance itself is still needed. Go and his associates reported that the Fukuoka consensus provided higher positive and negative values to predict high-risk IPMN than the Sendai guidelines. They concluded that the Fukuoka guidelines, consensus guidelines, are superior to the Sendai guidelines for initial triage of pancreatic cystic neoplasm. They also reviewed this many surgically resected patients with IPMN retrieved from the 7 previous reports. The positive predictive value of worrisome features was 29%, and that of high-risk stigmata was 66%. They concluded again that stratification of IPMN into high-risk group and worrisome feature groups resulted in a higher positive predictive value in the high-risk group. However, as 6% of malignant IPMN and 2% of invasive IPMN were worrisome feature negative, they stated that some malignant and even invasive IPMN may be missed by the Fukuoka consensus criteria. So A small proportion of malignant IPMN may still be missed due to the absence of any worrisome features, but the Fukuoka consensus is good in general. However, there are a lot of controversies about the surveillance of branch duct IPMN. The diagnostic method, interval, and the period of surveillance are not standardized yet. Frequent imaging studies by CT and MR at a 6-month interval justified in patients with branch duct IPMN without any worrisome features. Should the age of the patient be taken into account in consideration of the interval? How about lengthening of the surveillance interval after no change is observed? Furthermore, should the surveillance be continued until very advanced age? Should the surveillance protocol be changed for branch duct IPMN with worrisome features? And as to the method of surveillance, should the surveillance protocol include endosonography, and how often? And finally, should the surveillance be continued after complete resection of branch duct IPMN? Thus, there are many unsolved questions in the management of branch duct IPMN. In the meantime, the AGA guidelines for the management of asymptomatic pancreatic cysts were published in Gastroenterology in last year and have provided us with a big challenge. As you see in this algorithm, the AGA guidelines instruct physicians to stop surveillance in 5 years of no significant change in IPMN. The working group of the international consensus guidelines have a great concern over this point. It may probably be okay with the indexes on observation, but there is another story of IPMN. My concern arises from our experience with the development of ordinary type pancreatic cancer in the pancreas of IPMN patients. We have experienced 57 patients with concomitant pancreatic cancer in 570 consecutive patients with IPMN in our department. This is exactly 10% of all IPMN patients. Most of them are branch duct type, but main duct type and mixed type are no exception. I began to experience the combination of pancreatic cancer and benign IPMN in this particular patient. This is the first case in the world where I found a carcinoma in situ concomitant with a small benign IPMN. After I confirmed the origin of the positive cytology in the body or tail of the pancreas by endoscopic segmental balloon cytology, we performed left pancreatectomy in this patient. The origin of a positive cytology was confirmed again by segmental cytology during surgery too, and complete histological examinations revealed a carcinoma in situ or high-grade dysplasia in a branch close to the small benign branch duct IPMN. This is the second patient that I found 1 year later. During the ERCP of branch duct IPMN, the pancreatic juice proved to be positive for adipia. There was carcinoma in situ in the main pancreatic duct adjacent to the communicating branch of a benign branch duct IPMN. We reported this phenomenon as a sentinel for detection of a very early pancreatic cancer. These are patients who underwent PD for pancreatic cancer concomitant with IPMN. Number 12 and 13 are example of metachronous development of pancreatic cancer after resection of benign IPMN. You see the concomitant cancer occurring 2 years or 4 years after resection of the initial IPMN. Number 14 and 19 developed second pancreatic cancer after pancreatoduodenectomy to treat initial pancreatic cancer concomitant with benign IPMN. These two cases of second pancreatic cancer also occurred within 5 years. However, please take a look at these patients who initially underwent a distal pancreatectomy. In patient number 13 and 34, we found a carcinoma in situ during workup of an IPMN in the tail of the pancreas. We did distal pancreatectomy, but they developed advanced cancer again 7 years and 14 years later. So the development of pancreatic cancer concomitant with IPMN and the new carcinoma in the pancreas remaining after resection of IPMN or concomitant cancer is another concern in the management of IPMN. These phenomena may occur even at long term, not limited to within 5 years. So we have to be very careful about the possible presence of another cancer in the pancreas to be left after resection of cancer derived from IPMN or concomitant with IPMN. When a part of the pancreas can be left in place, lifelong surveillance is necessary on that part of the pancreas in patients with IPMN. These are patients whose concomitant pancreatic cancer was already unresectable at the time of diagnosis. This phenomenon has been drawing increasing attention, especially in Japan, and it's been reported that 2.0 to 9.2% of patients with branch duct IPMN had pancreatic cancer distinct from IPMN. The yearly incidence of carcinoma development has been shown to be roughly around 1% per year. This means that you are supposed to find out one patient with pancreatic cancer if you are seeing 100 patients with IPMN in your clinic every year. There are several reports on pancreatic cancer concomitant with IPMN from Western countries as well. This article is from Beaujon Hospital in Paris. CT and MRCP were performed in 53 patients with branch duct IPMN every 1 to 2 years for more than 5 years, depending on the cyst size, which were stable in 72% or increased by more than 5 millimeters in 15%. In this series, they found 2 pancreatic cancers concomitant with IPMN, both after 84 months follow-up. They concluded that imaging surveillance is still necessary beyond 5 years. The Memorial Sloan Kettering Cancer Center also reported a retrospective review of 107 patients with a branch duct IPMN on observation with median follow-up of 40 months. 97 patients ultimately underwent resection, and 79 proved to have non-invasive IPMN and 18 invasive carcinoma. Please note that 5 of the 18 invasive lesions developed in a region remote from the monitored IPMN. They concluded that diagnostic, operative, and surveillance strategies for IPMN should consider risk not only to the index cyst, but also to the entire pancreatic gland. Boston and the Verona group reported their combined series of 441 patients with IPMN. 7% or 31 patients had a distinct pancreatic cancer. 26 patients who underwent surgery for pancreatic cancer were found to have IPMN, and 5 patients who had resection of a mixed type IPMN were found to have a pancreatic cancer within their surgical specimens. So they concluded that attention should be paid to the development of concurrent pancreatic cancer, even in patients with low-risk branch duct IPMN. Regarding surveillance after resection of a branch duct IPMN, the Memorial Sloan Kettering group reported their result of follow-up of 78 patients who underwent resection for non-invasive IPMN for 40 months. 6 of all the patients had a local recurrence. 3 of them died, and the other 3 underwent additional resection. Patients with a positive margin for IPMN recurred more frequently than margin-negative patients. Their conclusion was that IPMN requires indefinite surveillance even after resection. We also reported 172 patients after resection of IPMN with a mean follow-up for more than 5 years. In this series of patients, distinct pancreatic cancer was observed either at the initial operation or during the follow-up in 17 patients, or 9.9%, a very high rate. Noteworthy is the fact that 6 distinct pancreatic cancer developed in the remnant pancreas after a mean follow-up of 84 months, or 7 years. So intense long-term surveillance is necessary for the early detection of the metastatic occurrence of distinct pancreatic cancer, as well as malignant progression of IPMN even after 5 years. We further analyzed 195 patients who underwent partial pancreatectomy for IPMN and found 13 metastatic high-risk lesions in the pancreatic remnant, including 6 high-grade dysplasia or invasive IPMN and 7 pancreatic cancers. The 5-year and 10-year cumulative incidences were 7.8% and 11.8% respectively. Noteworthy was the fact that high-grade dysplasia or invasive IPMN and IPMN located in the distal pancreas at the initial operation were predictive of metastatic high-grade dysplasia or invasive IPMN afterwards. Also, pancreatobiliary subtype of IPMN and the presence of concomitant pancreatic cancer were predictive of metastatic occurrence of pancreatic cancer. The Johns Hopkins group also stressed the importance of indefinite surveillance even after surgery for IPMN because of the threefold risks of developing a new IPMN or requiring surgery or developing pancreatic cancer. They pointed out that a family history of pancreatic cancer, but not margin status or degree of dysplasia, was associated with a risk of development of a new or progressive IPMN. They estimated the chances of developing invasive pancreatic cancer as 7% at 5 years and even 38% at 10 years. These authors, however, did not clearly distinguish concomitant pancreatic cancer and invasive IPMN. Regarding how to distinguish pancreatic cancer concomitant with IPMN from pancreatic cancer derived from IPMN, topological and histological distinction was proposed by a working group of Japan Pancreas Society, but the distinction sometimes remains unclear. Of 183 patients reported by Yamaguchi, 122 were carcinoma derived from IPMN, and 31 were concomitant cancer, but the remaining 30 patients had indistinguishable pancreatic cancer. In order to determine the incidence of concomitant pancreatic cancer as precisely as possible, we are using genetic analysis as well as histological findings. Genus mutation is frequently found in IPMN, and if positive in the carcinoma, it can be regarded as carcinoma derived from IPMN, as we reported in 2 articles. If the carcinoma is negative for genus mutation and IPMN in that patient is positive for genus mutation, it can be judged as concomitant pancreatic cancer. When both regions are negative for genus mutation, KRAS mutation will be used to further distinguish concomitant carcinoma and other biomarkers such as TP53, P16, and DPC4 may be helpful for that purpose. In this way, we could successfully distinguish the 2 entities in 92% of difficult cases. This Kaplan-Meier graph shows the cumulative incidence of significant lesions, including high-grade dysplasia, invasive carcinoma derived from IPMN, and concomitant pancreatic cancer, distinct from IPMN in our most recent series of 195 resected IPMNs. As you see, the incidences of both of malignant IPMN and concomitant cancer still rise even after 5 years. So in summary, the impact of surveillance of branch duct IPMN should be assessed by looking at the frequency of malignant transformation and its relationship to the appearance of mural nodule, the rate of growth of the cyst, and possibly the rate of an increase in the number of the cysts. And finally, the incidence of concomitant but distinct pancreatic cancer. Most of the previous reports emphasized that these phenomena have to be surveyed indefinitely, and it's probably right and important in the assessment of surveillance of branch duct IPMN. If you follow the AGA guidelines, and your patient should develop pancreatic cancer concomitant with IPMN in 6 years after the diagnosis of IPMN, that patient will miss an invaluable chance for early detection of pancreatic cancer. You have to make a choice between these 2 guidelines, which are very different in the surveillance strategies. The Japan Pancreas Society is now doing a prospective multi-center study to clarify the true incidence of pancreatic cancer and the best method and the interval of surveillance in patients with branch duct IPMN. More than 2,300 patients with branch duct IPMN were registered through a website right after the initial CT, MRCP, and EUS. And further, CT or MRCP and blood tests are performed every 6 months, and the EUS is added every year. We are expecting the result in 2020, the year of Tokyo Olympic Games next to Rio in this year. So my conclusions at this moment are an adequate surveillance protocol needs to be determined to revise the consensus guidelines. More attention should be paid to the development of concomitant but distinct pancreatic cancer during surveillance without resection and even after resection of IPMN and or pancreatic cancer. And lastly, there have been previous reports on these phenomena even after 5 years, while there is no evidence to justify stopping the surveillance in 5 years of no change. So I would like to tell you again, that you have to make a wise choice between the international consensus guidelines or the AGA guidelines when you see your patient with IPMN in your daily practice. Thank you for your attention.